Dear participants, my name is Dr. Julia Zając, and I have a great pleasure to welcome you back after the summer break at the fourth EuroBloodNet's Topic on Focus Cutaneous Lymphoma webinar. And before we start, I have a few technical suggestions. Please mute your microphone and switch off your cameras to maintain better streaming quality. And please make sure you enter your full name and surname in the WebEx. What is important if you would like to receive accreditation after attending the whole cycle of webinars. At the end of the lecture, as you probably might know, it will take place discussion. And if you have any questions about the presentation, please write it in the chat. And you can find it under the cloud symbol and where you can see now the test message. And dear audience, please welcome with me today's speaker, Professor Werner Kempf, who will tell us about CD30 plus lymphoproliferations. Professor Kempf is co-director of Dermatopathology Laboratory Kempf und Pfalz Histologische Diagnostik, lecturer and consultant in the Department of Dermatology at the University Hospital Zurich, and president of the International Committee of Dermatopathology. During his career, Professor Kempf has held many prestigious medical and scientific functions, among which Vice President of the International Society of Dermatopathology, President of the Swiss Group of Dermatopathology, and Executive Board Member of the International Society of Dermatopathology. Professor Kempf's research activities are focused on cutaneous lymphomas, oncogenic viruses, skin tumors in organ transplant recipients, and photodynamic therapy of skin tumors. His medical and scientific achievements were awarded with internationally recognized prestigious awards. And additionally, Professor Kempf is member of many dermatological and dermatopathological societies, including ERTC Cutaneous Lymphoma Task Force and International Society of Cutaneous Lymphomas. He's also member of editorial board in various journals, such as American Journal of Dermatopathology, Journal of Cutaneous Pathology, International Journal of Dermatology, and Skin Health and Disease. Moreover, he authored 290 publications, 50 book chapters, and co-edited 6 books. Professor Kempf, the floor is yours.
Julia, thank you very much for this kind introduction. Good afternoon. It's a great pleasure and an honor to continue with the webinars with the topic of CD30 positive lymphoproliferative disorders today. These are my conflicts of interest. Well, the idea behind this webinar is to give you an insight into the spectrum of cutaneous CD30 positive lymphoproliferations with a focus on the diagnosis and treatment. When we talk about primary cutaneous CD30 positive lymphoproliferative disorders, it's actually the second most common group of cutaneous T-cell lymphomas. Then we do not talk about one single disease, but a spectrum which spans on one hand from lymphomatoid papillosis, which you see here on the left side, to the other end of primary cutaneous anaplastic large cell lymphoma. So these two diseases, or the entire spectrum, has been included in the most recent lymphoma classifications in the WHO classification 4th edition, as well as in the updated WHO ERTC classification with these terms, lymphomatoid papillosis and primary cutaneous anaplastic large cell lymphoma. So the common denominator which brings these two diseases into one spectrum is actually the expression of CD30 by the neoplastic cells. This marker has been discovered in 1982 by the group of Harald Stein in Berlin and characterizes the neoplastic cells. It's a member of the tumor necrosis superfamily, And it is not only a diagnostic marker, but has become nowadays also a therapeutic target. Now, when we start with one end of the spectrum, the cutaneous anaplastic large cell lymphoma, it presents usually with rapidly growing large nodules, several centimeters in diameter, which tend to undergo ulceration. The predilection sites mostly head and neck and extremities, and almost half of the patients present, as you see here on the right side, with solitary lesions. Remarkably, and we will see this phenomenon in the entire spectrum of CD30 lymphoproliferations, also anaplastic large cell lymphoma has a tendency for spontaneous, mostly partial, but spontaneous regression in up to 40% of the cases. The histology is in the classic form a dense nodular infiltrate which consists of medium-sized to large, highly pleomorphic tumor cells, as you can see here in the mid image. By definition, but in most cases, we have expression of CD30 by almost all tumor cells. By definition, it has to be more than 75% of all tumor cells expressing CD30. And there is a variable expression of additional T cell markers. There are clinical as well as histological variants of the disease. You see here in the upper row a so-called neutrophil-rich variant, which presents almost like a pyoderma gangrenosum with only scattered CD30 positive tumor cells in a background of numerous neutrophils. And there are also immunophenotypic variants, which are very rare, like the ALK-positive anaplastic large cell lymphoma, which has been recently described as a new phenotypic variant. Now, we have to be aware when we talk about CD30 expression in cutaneous lymphomas that despite lymphomatoid papulosis and anaplastic large cell lymphomas belong to the group of CD30 positive lymphoproliferations, there is a very wide spectrum of other T cell lymphomas, but also of B cell and NK cell lymphomas, which in a variable degree may express CD30. That has a consequence. So if we see histologically infiltrates of CD30 positive cells, we have on one side to think to the CD30 positive cutaneous lymphoproliferations, lymphomatoid papulosis, and anaplastic large cell lymphoma, but we always have to consider other forms of lymphomas which can be much more aggressive. And just to give you an example, if we see an infiltrate of CD30 positive medium-sized to large tumor cells, these four entities can be behind this histology. So that means, in a consequence, you need a clinical pathologic correlation as a crucial element in the diagnosis. It's not that we can make a definite diagnosis at the microscope. As pathologists or dermatopathologists, we can provide a list of differential diagnoses, and in collaboration with the clinician, we can then come up with a final diagnosis. That's a very essential point in the diagnostic workup. Of course, these patients need to undergo staging by radiology, either CT or more ideal PET-CT, investigation of peripheral blood, and at least some of the experts recommend also bone marrow biopsy. By this process, other lymphomas can be excluded, and then we come up finally with the diagnosis of anaplastic large cell lymphoma. The TNM classification is according to the publication by Kim and co-workers in 2007 in Blood, and distinguish, as you can see here, the solitary lesion from the regional involvement, which means you have a cluster of tumoral lesions within one body area or two contiguous body areas. And this has to be separated from the T3 stage, with multiple body areas involved and generalized lesions, what we call multifocal distribution. Now, for all of you who are familiar with the systemic anaplastic large cell lymphoma, genetic alterations have shown to be of prognostic impact and have also a tremendous impact in the diagnosis. So far, despite some of the cases of primary cutaneous anaplastic large cell lymphoma carry these genetic alterations, so far there is no link to the prognosis or to therapeutic response. This should be distinguished if we talk between systemic and primary cutaneous anaplastic large cell lymphoma. Now, what is the course of the disease? And if you think back to this clinical presentation with rapidly growing tumors and the highly malignant appearing histology, it is absolutely surprising that the course is characterized by an excellent prognosis. The 5-year survival rate and even the 10-year survival rate in primary cutaneous anaplastic large cell lymphoma is above 90%. Nevertheless, despite the prognosis is excellent, almost half of the patients experience recurrence, and fortunately, only a minority of the patient has an extracutaneous spread, and even less experience or die due to the lymphoma. So this is indifferent to systemic anaplastic large cell lymphoma and should be emphasized that primary cutaneous anaplastic large cell lymphoma has an excellent prognosis, which has then important implications for the therapy. What are prognostic factors? An impaired prognosis is seen particularly in patients with multiple lesions at presentation, so-called multifocal ALCL, those with an extensive lymph involvement, like you see here on the right side, and patients who have an extracutaneous spread of the disease. In addition, patients under immunosuppression experience a highly aggressive course of their disease. Now, the treatment follows the guidelines of primary cutaneous lymphomas as stated in the ESMO guidelines. For example, in 2011, 3 lymphoma societies have put together a kind of consensus recommendations for CD30 positive lymphoproliferative disorders. Now, when we face the situation, and that is in the vast majority of the patients, that they present with a solitary or localized tumors, then there are 2 first-line treatment options: surgical excision and local radiation therapy. Remarkably, the safety margins in surgical excision are still completely undefined. In local radiation therapy, there are different schemes applied, sometimes even with low doses, which, however, show good response rates. And you see here very high response rates. Nevertheless, independent whether you take surgical excision or radiation therapy, the relapse rate is about 40%. Now, what is important, and in difference to systemic anaplastic large cell lymphoma, chemotherapy and with anthracycline-based protocols is not indicated in patients with solitary or localized tumors in primary cutaneous ALCL, because the relapse rate is very high, definitively higher than for surgical excision and radiation therapy. Now, a challenging situation is in patients with multifocal tumoral lesions. Fortunately, here we have new data, particularly from the Dutch group, from a large archive on these patients. And it shows that when the patients present with more than 5 lesions, methotrexate in a low dose scheme, that means 20 milligram per week, has good response and can control the disease. Or alternatively, if you have less than 5 lesions, radiotherapy of the lesions is an option. For those patients who show not a response to methotrexate or have relapses, brentuximab vedotin, so the anti-CD30 targeted therapy, is nowadays a good option. For the few patients with extracutaneous spread, there the data are even more sparse, but in those patients, either brentuximab vedotin or multi-agent chemotherapy are indicated. Just one little note, but it's important: if you have a patient with anaplastic large cell lymphoma of the skin and only local regional lymph node involvement, these patients have an excellent prognosis and can be treated with radiotherapy. Now, just with the brentuximab vedotin, even with that treatment, you get high response rates, but the complete remission rate is only about 30%. So still there is a need for efficient therapies. And we should not forget, of course, the adverse effects, which are seen in almost 40 to 50% of the patients. Now, let me switch to the other end of the spectrum of cutaneous CD30 positive lymphoproliferations, which you see here on the left side, lymphomatoid papulosis. This disease has been described years or even decades before CD30 became discovered by Warren McCauley, who you see here on the left side. He observed patients who presented with papules and small nodules and the same histological features as you can see in anaplastic large cell lymphoma. Interestingly, these lesions, the individual lesions, have a tendency to disappear by themselves without any treatment after a few weeks or sometimes 2 or 3 months. And based on that, he called the disease lymphomatoid papulosis. That's the typical manifestation, either localized or in most patients multifocal papules and nodules, which are usually less than 2 centimeters in diameter. In most patients asymptomatic, some patients report itching. And the most important, this tendency that every individual lesion undergoes spontaneous regression after a few weeks, sometimes leaving behind a slightly depressed scar, as you can see. Now, the clinical presentation is quite uniform in lymphomatoid papulosis. However, the histological spectrum is enormously broad. And the most common type is that what you see here, a wedge-shaped infiltrate which contains the large, highly atypical neoplastic cells intermingled with reactive cells, neutrophils, eosinophils. Again, CD30 is the most important marker. So despite the histological spectrum is so broad, it has no prognostic impact. So it does not play any role whether you have histological type A or B or E. The biological behavior of all those is the same. What is important from a diagnostic point, each of these different types, and that is the reason why they have been separated and included in the classifications, can mimic a much more aggressive form of lymphoma. And I would like to show you, just as an example, LYP type B shows an epidermotropic infiltrate. So behind this histology, you can either have a patient with lymphomatoid papulosis when the patient presents with papulonodular lesions and spontaneous regression, or the same histology you can see in mycosis fungoides, but then those patients present with patches and plaques and not with spontaneously regressing papular lesions. Now again, like in anaplastic lymphoma, this demonstrates that clinical pathologic correlation is absolutely crucial for the diagnostic workup. What is the therapeutic management? If the patients present with only a few lesions, There is not a mandatory need for an active treatment. We can also follow a wait-and-see strategy. If one would like to do a treatment, then UV light-based treatments like Soralen, UVA, or UVB narrowband turn out to be effective, or also low-dose methotrexate. In some larger lesions which may persist for longer time, excisional radiotherapy similar to anaplastic large cell lymphoma can be applied. In the majority of the patients where you have generalized lesions or stigmatizing lesions, for example on the face, either you can go with UV light treatment or low-dose methotrexate. And following here a Dutch scheme, we do the same. We start with about 10 milligram once a week and then increase the dose. Usually between 10 and 20 milligram is sufficient to control the disease. However, and again, similar like in anaplastic large cell lymphoma, when you look to the relapse rates, you see as soon as you stop with these treatments, there is a high recurrence or relapse rate. And that means that the treatment options we have in lymphomatoid papulosis are effective in controlling the disease, but rarely we see cure. Of course, the disease by itself can stop, but the treatment just makes some interruptions to the course. And so far, there is no proof that any treatment really alters the natural course of the disease. Nevertheless, despite the disease has an excellent prognosis and patients do not die due to lymphomatoid papulosis by itself, a remarkable number of the patients are at risk to develop other hematologic neoplasms. And therefore, patients should be followed over a long time to discover these second neoplasm. And this has been shown in a recent study, again from the Dutch group, about 11 to 15% of the patients are at risk to develop a second hematologic neoplasm. So far, we have no unambiguous prognostic factors to identify those patients who are at risk to develop a second neoplasm. So in summary, I showed you the spectrum of CD30 positive lymphoproliferations. On one hand, in cutaneous anaplastic large cell lymphoma, most of the patients, or at least half, present with a rapidly growing solitary tumor, mostly on the head and neck or on the limbs. Despite this rapid growth and the malignant appearance of the histological features, the prognosis is excellent with a 5 or 10 year survival rate over 90%, but is impaired in those patients who have extensive lymph disease or extracutaneous spread. Excision and radiation therapy are the first-line treatment for the patients with solitary or localized disease. For those with multifocal disease, methotrexate in a low-dose scheme or brentuximab vedotin are therapeutic options. In lymphomatoid papulosis, we have this very characteristic, unique presentation with these recurrent papillonodular lesions, and every individual lesion undergoes spontaneous regression after a few weeks. Despite the clinical presentation is so typical, the histological spectrum is very broad, and this is important for differential diagnosis. Lymphomatoid papulosis patients should be followed over a long time due to the risk to develop a second lymphoid neoplasm in about 15% of the patients. First-line treatment is either just expectant observation, UV light-based treatment, or methotrexate, again in a low-dose scheme between 10 to 20 milligram per week. And just to finish, in the diagnostic workup of CD30 positive lymphoproliferation, it's absolutely essential always to be based on a clinical pathologic correlation to differentiate CD30 positive lymphoproliferation from its mimicker, other cutaneous or systemic T-cell lymphomas. So thank you very much for your attention, and yeah, I'm looking forward to questions.
Thank you, Professor Kemp, for this comprehensive presentation. And now I would like to invite the audience to ask questions.
Yeah, this is a question from Pablo Ortiz from Madrid. He says, I have a question about a difficult patient. It is a kidney transplanted woman with multiple skin lesions of primary cutaneous anaplastic large cell lymphoma and regional lymph node involvement. What do you suggest for treatment? The data on patients with CD30 positive lymphoproliferation in organ transplant recipients are quite limited. So far, one has to say that the prognosis is very dismal, about 50% mortality rate. And I think indifferent to the immunocompetent patient, here in an organ transplant recipient, I would go for a treatment. One could try with methotrexate, but if there is no response with a reasonable time, like 2 to 4 weeks, then I would definitively change to brentuximab, or in those patients, even to chemotherapy, due to this very dismal prognosis. Then there is another question from Netherlands, Martha Becking. He writes, I have some patients with LYP and rheumatological problems. Should I cautious with systemic anti-inflammatory agents like anti-TNF biological? Is there a chance of inducing systemic lymphoma? Yeah, it is a very important question, as we see this phenomenon in other T-cell lymphomas, mycosis fungoides. So far, at least to my knowledge, there are no data really showing a similar effect like in MF, but actually I would not be surprised to see also a negative impact. So I would be rather reluctant and to try to avoid anti-inflammatory agents like anti-TNF biologicals. But I think there is definitively a need to summarize these experience from different centers. Maybe that could be done in the context of the EORTC cutaneous lymphoma group. Then there is another question, how often would you recommend imaging for cutaneous anaplastic large cell lymphoma, and how often should laboratory values be controlled in patients with LYP regarding the risk of secondary hematological malignancy? There are no definite recommendations on that. Actually, for anaplastic large cell lymphoma, I would recommend the imaging once a year. For lymphomatoid papulosis, the laboratory values also, we do it about once a year. One has to say leukemias, fortunately, are not the most typical second neoplasms in lymphomatoid papulosis. It's really mycosis fungoides and cutaneous and nodal anaplastic large cell lymphoma. And so the skin examination is probably more important than the laboratory values. I hope this answered the question here. Then there is another question from Dr. El Sayat, a pregnant woman with a rapid progressive lesion on her arm, about 8 centimeters in diameter, and they would like to start radiation this week. Do you have any other possible therapeutic option? No, I fully agree. For me, also radiation treatment in this situation is the ideal treatment, particularly as, of course, the whole abdominal area is perfectly protected if the lesion is on the arm, and all the other treatment options are not really an ideal indication in the context of pregnancy. So I would also go with radiation treatment. Yeah, that is an interesting question from Denmark regarding the borderline cases. Are they mostly atypical clinical? I have not touched this issue. You have seen it on the third PowerPoint slide, that in the middle between lymphomatoid papulosis and anaplastic large cell lymphoma, there's a third group, borderline cases. And actually, it's not an entity by itself, it's rather a working diagnosis. Sometimes we have really weird constellations where we have rapidly growing tumors, but the histology is that of a lymphomatoid papulosis, for example. And for those lesions where histologically and or clinically we cannot really decide should we put that into lymphomatoid papulosis or anaplastic large cell lymphoma, we tend to call them borderline cases. In my experience, after several months, usually the clinical presentation gets more clear, and it is easier than to put it in one or the other entity, so LYP or IALCL. But I agree that cases what we have used the term borderline, they have really a typical clinical presentation. And one patient, for example, showed a rapidly growing ulceration on the shoulder. The histology was the one of an LYP, and despite the lesion was large, 6-8 centimeters, it showed a spontaneous or almost complete spontaneous regression, so that the lesion at the end was only 2 centimeters. So, and for such a constellation, which is atypical, I use the term borderline case. But I think so. If somebody would be interested to summarize borderline cases, would be an interesting project again. Could you comment? That's the next question. Could you comment on breast implant associated anaplastic large cell lymphoma? Actually, I don't feel that I'm the right person to answer this question, as I do not have personal experience with breast implant associated anaplastic large cell lymphoma. It seems that some of the biology is similar to cutaneous anaplastic large cell lymphoma, and also some of the genetic alterations show an overlap. But as it is stated here in the comment, so far it seems that this tendency for spontaneous regression is different between breast implant associated and skin or primary cutaneous anaplastic large cell lymphoma. So I think there are definitively other experts who can make much more detailed information. Maybe one remark, if there is no other question, we get from time to time consultation cases with the question how to treat lymphomatoid papulosis in childhood. Because the data and the literature are still quite sparse on these issues, and we always start with topical steroids. In contrast to adults who usually do not show a very good response to topical steroids, it seems that children respond better. The other point is that in children, one is more reluctant with UV light treatment and, of course, low-dose methotrexate, because due to the cumulative effect, if one would have to give that over years or even over several months. So that in children, I think we have a little bit different situation than in adults. Nevertheless, these children should be followed for a long time because also they have an increased risk for a second neoplasm. Another question, the genetic analysis of biopsies in cutaneous anaplastic large cell lymphoma, is it necessary? In contrast to systemic anaplastic large cell lymphoma, where these mutations or genetic alterations have a prognostic impact and also implications for the treatment. In cutaneous anaplastic large cell lymphoma, so far, none of these alterations have been shown to be really of prognostic impact. Still, we have only a few series analyzing the genetic background of ALCL, but so far without any prognostic impact. So, I would say genetic analysis so far is not mandatory in primary cutaneous anaplastic large cell lymphoma. Okay, thank you very much. It was a great pleasure, and yeah, have a nice evening.
Thank you very much, Professor Kemp, for leading this great session on CD30 plus lymphoproliferations. And of course, thank you, audience, for participating in this event. Please do not forget to fill in the survey we will send you at the end of this session. And of course, please be informed that the next session will take place the 28th of September, and we highly encourage you to participate. And in meanwhile, I would like to invite you to subscribe to our newsletter, so you can get all informations on what we are working on currently at EuroBloodNet. And of course, follow us on Twitter, LinkedIn, and Facebook. And please visit us at EuroBloodNet's Edu YouTube channel, where we publish all the webinar sessions, also from today's webinar cycle. Thank you very much, and see you next time.